I have the privilege to introduce the Chairman of the Board of Chancellors, Dr. Bibb Allen.
Good morning. It is a privilege to give you this annual update from the board to see if we're doing the things that you've asked us to do. This will be my last update. It's been a real privilege to serve as the board chair. The board will be in very capable hands come Tuesday with Jim Brink as the chair and Geraldine McGinty as vice chair. What I'd like to do is, again, last year we went through a little bit of the strategic plan. That was one of our big exercises for last year. And as you recall, what we ended up with to serve patients in society by empowering members. And all of this is about value. So what I want to do today is to continue on the theme that Bill has set for the meeting and talk about the value proposition around members and member engagement. So as you can see, this involves members and diverse practice types, young physicians. You have a resolution now to consider adding a young physician section representative to our board, and we're excited about that opportunity. But senior members, the whole gamut of practice types. Because our goal is that the ACR become every radiologist's career partner from when they begin their training through their entire career, and as senior and retired members to have a conduit to give back some of the sage wisdom that they've learned. Now, when we talk about value, your survey for our strategic plan told us economics was forefront. All of the things that we do here in economics that benefit all radiologists, not just members of the college, and we'll talk about that as we go along. But I'm going to be less politically correct and just talk about it right here now, that if you're in medicine, you're in politics. There's no way around it. I know you're tired of seeing this slide of President Johnson and me, and knowing that I got my career started in economics for the college back in 1964. Yeah, now you believe it. This is getting really bad. But I'm always reminded, and I know I showed you this last year, nothing in this title when they did the Medicare Act shall authorize any federal officer to exercise any control over the practice of medicine. Well, the times have changed, right? And so, this slide of the 6 cuts in the last 12 years, but you gotta think, the MPPR, a 25% payment reduction for second and subsequent exams, was just crazy. There was no basis. This was a bureaucratic money grab to give money from radiology to primary care. And I'll always be grateful to John Petty for coming up with the idea of, well, why don't we take a paper and why don't we look at all the data that's available in the RBS and do this? And so we did it, and a bunch of us, we went on this road show with MedPAC and at CMS and the Office of Management and Budget to try to convince policymakers that we had the data and they were just wrong. We even got Dr. Don Berwick, who was then the administrator of CMS, to visit some radiology centers, this one in Minnesota. And again, this is the first time RadPAC helped us, because Betty McCollum in Minnesota, who set this up for us. But we needed a legislative solution. And we understood that if we could target our members of the Ways and Means Committee, the House Energy and Commerce Committee, and the Finance Committee, that we could get this message across that we weren't advocating for more money for radiology. What we wanted them to do was to exert their pressure on CMS to help correct a payment policy and reestablish appropriate reimbursement. So I want to pause and just remind you that when you go to Congress this week and you thank the members of Congress for this, remember to couch it in correcting improper payment policy at CMS rather than a windfall of money for radiology. And of course, we had MPPR champions. Fred Upton, in this independent expenditure we did for him, all the legislation that got adopted later came through Energy and Commerce. And of course, with the for a time there, we had Steve Ferrara as a fellow on the Energy and Commerce Committee. So it was a good time for radiology. And so the first thing that Fred helped us with was the PAMA that did the decision support instead of RBMs in the Medicare system. And so we were very appreciative of Fred and gave him the CARE Award last year's meeting. I hope some of you were there for that little ceremony up on Capitol Hill that we did. But Fred's work wasn't done, right? So in the 21st Century CARES Act, he had a proposal that eliminated the multiple procedure payment reduction. And we thought that this was just going to languish. We didn't know whether the Senate was going to do anything with it, but we were very pleased. Well, lo and behold, when it came time to do budget reconciliation, or what they call the Consolidated Appropriations Act, it reduced the multiple payment reduction from 25 to 12%, and it also incorporated the PALS legislation protecting access to screening mammography in the wake of the task force recommendations. Well, that was pretty good, but Fred's work wasn't done again, because he said, guys, 12% is not right. They have data. They have data that shows that it's 5%, indicating again the value and the importance of the Health Policy Institute, now which was our arm to create these types of things that could get this message to Congress. And so, when President Obama signed the budget reconciliation, it was a 5% MPPR reduction. The greatest work of the college on behalf of our members. It will redistribute back $350 million to radiology over the next 10 years, and in perpetuity, really, going forward. And so my thanks to all of you who were part of that process. But remember, we have new horizons now, and our strategic plan tells us to advocate for new payment models and to make sure that they recognize the value that's being delivered by radiology. And this is what you guys do when you go up there. You educate, you align incentives, because, as Steve Jobs said, people won't know what they want until you show it to them. So that's what you do. I can't thank the council enough for embracing this concept that came out of economics for Imaging 3.0, to have a value proposition to talk about for our referring physicians, for our health systems, and for the government, to show them that we can be part of the solution, and at the same time put our patients in the center. But you know, I can't stand it when we use these little stick figures for our patients, because these are our patients, these are their families, and that's what we're talking about. And it has allowed us to produce our Commission on Patient and Family-Centered Care that we did for the board, and it allowed radiology to actually be considered a leader as far as patient-centric care goes. But despite all that, more and more you're going to have to document and prove our worth to our health systems, our colleagues, and our patients. And we stand ready at college to be your partner in doing just that. I talked about the importance of the HPI and the work that did, and I want to give a shout out to Advanced Radiology Services from Michigan. In 2015, they gave a $100,000 contribution to our ACR Foundation for the HPI, and this year they've given a challenge to all of us, that they'll do it again if from all of us we can give another $100,000 to the foundation. I hope everybody will go visit the foundation booth and make that happen just right here, right now at this meeting, so we can get $200,000 of grant money from us, from our specialty, to help the HPI. Because, as Jim Brink says in his first article of the bulletin, adding value isn't an option anymore. This is your friend Sylvia Burwell, the Secretary of HHS. 85% of Medicare payments fee-for-service by 2018. So that leads us to the main thing, the next main thing that you told us in the survey that we needed to pay attention to is quality. And look at all of these quality programs that we're doing to help get that in place so we can have our patients' quality at the forefront. Establishing radiology professions as stewards of our patients' entire radiological care and increase the range of tools. So the dose index registry for our typical part, our traditional part of caring for patients, helping our referring physicians order wisely with ACR Select, And our new initiatives like ACR Assist to help us report more wisely, and then of course our registry program that'll let us communicate wisely not only internally within the health system, but to help report those metrics to CMS so we'll be on the pathway to MACRA compliance. So our message to our members for value is that these are practical and meaningful metrics developed by radiologists for radiologists. Workflow integrated solutions for ordering and reporting, and then seamless communication tools for communication and documentation. And that's the message that we're taking to the regulators, because we're ready. 2015, last year, I told you about the MACRA. Right off the bat, Geraldine developed a work group that pulled every commission of the college into getting us prepared. By fall, we had a 34-page response to CMS's request for information. And when they published the proposed rule, they called us and said, what did you like? What did you think about the proposed rule? How did you like it? What can we do better? We're engaged. We have a different story, a different message. We're being seen as part of the solution. And when you can look, MACRA venerates AUCs as an important part of that. And even though ACR Select is getting pushed back a little bit maybe or CDS to 2018, ACR Select is ready to be the decision support tool for our ordering physicians. In the interim, you can get CPIA credit in the MACRA for participating in RScan. So I hope everybody goes out and visits the RScan booth, because that'll be easy for you. The Dose Index Registry is another important tool that was venerated in the MACRA legislation about reporting dose and patient safety. And yes, even ACR Assist, that's barely in its infancy, but we've got metrics around reporting incidental abdominal lesions and incidental thyroid nodules in the MACRA that'll be available as part of ACR Assist. Communication, CMS goes on and on about using registries to report these metrics. If you look everywhere, you can see QCDR, Qualified Clinical Data Registries. That's what we're all about. That's what our registries do, whether you're an individual or whether you're a group. Now, these guys are going to give you a whole lot about the MACRA, I'm sure, this afternoon, but there's some things they're not going to tell you. For most physicians, this is the way it looks. 10% for cost, 25% for health IT. But there were some provisions in there that radiologists could never comply with. And oh, by the way, we can't totally control the costs. So for radiologists and other physician categories like that don't have the ability to control costs, CMS says it's zero. If you have a chance to pat Greg Nicola or Zeke Silver or Geraldine McGinty on the back for getting that as part of this regulation, that is a wonderful thing. Because as you look, now we'll redistribute that to quality and clinical practice improvement. As we go forward, you see that they have an increasing reliance on cost. I don't know whether we'll remain exempt, but until we can figure out how we can have some cost solutions, this exemption is very, very important for our practices. Now, it's a budget neutral thing. There are winners and losers. $833 million are going to be distributed. A little up, a little down. CMS thinks we're about right in the middle. And the question is, where will your practice be? Will you get a bonus or will you get a reduction? CMS recognizes that they've set it up for primary care to win. Diagnostic radiology is on the bottom of this list in blue. All the primary care specialties are ahead of us, and even the hospital-based physicians are ahead of us in what CMS's prediction is going to be of MACRA compliance. I hope we can do everything we can to prove them wrong. But what if you just want to be a report generator and say, I don't care about the money, a few extra scans, I'll make that up. Well, Zeke points out on his Physician Compare website, this is me, I'm doing quality activity, I'm participating in MOC, but what if that was a big no? Well, what are your hospitals going to think? What are your patients going to think? And oh, by the way, what will the groups do that are trying to take over your practice tell your hospital administrations? So I think it's important for every radiologist to be on this path to participate. And this is where I'm going to blow up my time a little bit because Dr. Emanuel made me a little frustrated yesterday, as you might imagine. But I won't comment in the reference committee, so I'll give you the time back. How about that? When we thought the macro was coming out, there'd be all these things. And remember, he talked about the bundled payment initiatives as being part of an alternate payment model. And so my second question to him was going to be, well, what do you think happened that CMS didn't put this in the advanced APM group that we can get credit for? If you look there, will medical homes qualify? Oh, by the way, the oncology care model is in there, the only specialist model that I saw in the whole thing that's approved. So I think, let's consider the source a little bit. Dr. Emanuel didn't talk anything at all about how we're going to manage the number of patients who are going to be ill because of the demographic. Our demographic is growing to older people. Older people demand more imaging. He pushed off precision medicine like it was some crazy thing. But the second iteration of CDS is going to be data mining tools that'll be able to not only help us with the patients where imaging is considered not appropriate, but how about all those patients that are out there that we can find with precision medicine and other tools by data mining their electronic health records to know where imaging can help them, get them out of the hospital sooner, and be a big resource. He's worried about what we think about whether patients are at home and their beds weighing them to tell them whether their heart failure is better or worse. That's great. That's not what we do, right? We take care of the people that need our care. So forgive me for that little iteration. But there's not much in these alternate payment models for radiology. Big numbers to participate. 75% by 2020 or so of your payments have to be in APMs to qualify. It's going to be a big risk. So should we just say, well, no, we don't want to worry about it? Well, 5% of your bonuses, incentive payments for the first 6 years, a 0.75% conversion factor update with no budget neutrality requirement. Look at the MIPS, budget neutrality, only a 25% update and no incentive payments. So they're really trying right now in this proposed rule to create a dichotomy between what primary care physicians can do and what specialists can do. So we're going to keep pushing because we've got great tools to help our members in risk-sharing contracts, whether it's capitation or ACOs or bundled payments. Because I want to congratulate Danny Hughes for updating our ICE-T application now, because you can learn from the HPI website what the average spend is for radiology Part B for any inpatient DRG. This is a huge tool. This is the spend for joint replacement, for instance, uncomplicated on the right, complicated on the left. So here we are, a pretty picture from rural Alabama. Nice, lots of back roads. Great for leisure. Hope everybody comes visit. But no place to work, right? We need to be able to comply with these macro things as part of our workflow. Because data that report in 2017 is going to provide the basis of our payments in 2019. We need to be on the superhighway. And I believe that we have the tools and the reporting capabilities from what we talked about for the ACR to be the fast lane for maximizing radiologist payments under the MACRA, defining meaningful metrics and measures for radiologists by radiologists, cost-effective, workflow integrated, can't emphasize that enough, and then seamless reporting to CMS and to the board. So as you look, we started with Imaging 3.0 for a culture change. We told you about ways others are doing this culture change, ways to do it. We've created now a toolkit aligning incentives with the MACRA gives us this ability to reinvent ourselves, to tell a better story about us, and oh, by the way, be ready to comply in a seamless manner. Do we want to be a report generator, or do we want to be part of the clinical team? Do we want to be a commodity, or do we want to be a resource to our health systems and servants to our patients? I think we're in a great position to adapt to health reform, and I think telling this story helps us attract the next generation of radiologists. So I'm proud that the board has been able to set this path and lead change. But you guys have all these ideas out there swimming around in your head. And the board wants to be informed by the council of things to do because we want to lead this change together. We want to have every radiologist in the country on board. Now I'm going to close with back to politics. Well, everybody knows that RADPAC doesn't support presidential candidates, but, you know, I'm frequently asked who would be better for radiology. Well, if you're considering a third party or an alternate, I might throw this out. 16 and 16 sounds like a pretty good ring to it, right? I mean, just saying, just saying. So, guys, many thanks. It's been a real pleasure being able to lead the board and be your board chair. The speaker tells me in order to do like an emergency resolution, I have to have 100%. I did have this, uh-oh. Oh, anyway, thank you very much. I appreciate everything. Bye-bye.